going back to some of those patients that you so that you tend to use this on whenever you can, right? So
Yeah.
I can only imagine, we talked about it, 3 to 4 centimeters. I've assumed TA disease, so kind of things that are kind of cauliflowery, papillary disease, are ideally suited for this, right? Do you use this for CIS patients when you see CIS as well? Is there a certain
Yeah.
grade that you say this is better for, not better for?
So when we look at the data, we tend to see the biggest benefit in the TA patients.
Okay.
So they seem to have the lowest risk of recurrence. But I do use it for kind of all comers, TA, T1, T2
Okay.
even. Um, and with CIS, what's nice is it's not very bulky, so you can actually
Yeah.
increase the surface area that you're resecting to pretty large surface area. But you got to think about how big of a flap you're now going to be lifting up and undermining, and what areas of the bladder you're going to go into. So you kind of have to balance maintaining safety
Mhm.
with getting as large a resection as you can. But I have done it for basically all states, from CIS
So,
to TA to T2.
so talk to me a little bit when you're saying you did it for T2 disease. I mean, this is technically patients have already have invaded into the muscle,
Mhm.
and at least the T2 disease that I tend to see most of it, is very bulky. Like these tumors are large. How do you
Yeah.
really do an en bloc resection on those really 5, 6, 7 centimeter tumors? My assumption is you can't, right? That's
No,
really
I
not
don't even
right.
try.
Okay.
If it's that large, I don't bother in the beginning.
Yeah.
So the very large tumors, I don't do an M block. But if it's a small tumor, sometimes you will have an invasive, 3 centimeter tumor. It happens. It's rare,
Yeah. Yeah.
but you do, and it's just
And that's probably the patient that you'd use it for. Yeah.
yeah, and you can actually kind of see it. It's really amazing because
Yeah.
with laser you get such good hemostasis that you can just be like, oh, this is normal muscle, normal muscle. What this is not normal. I'm concerned about this area.
Sure.
And so, that person, I would actually probably complete the en bloc resection. And if I had some ambiguity about there being residual disease, I'd probably get the path and bring them back and do a resection potentially,
Yeah.
or I would get the tumor off and resect the base separately as with a loop. If I was really confident that there was muscle invasion into the disease, 'cause I want to try to get them as close to T0 as possible before we go down our next treatment paths. You know,
Have you ever tried using frozen sections in this scenario,
I haven't done
doing
it
on
yet.
block? Yeah, and
No.
I suspect the reason why, I mean, maybe there's people out there, in the audience who are doing this, but I think at least in our practice, when by the time you send a frozen section, the pathologist reviews it, it's probably a good 20, 25 minutes, and I'm not sure we're just waiting in the OR. It's a good use of that time to sit there and just wait for a resection to see if you want to go any deeper. So I suspect the timing may not necessarily work out for frozen sections, but if that ever changes, that may be an interesting concept to explore.
Here's some interesting data that I kind of think about a lot is that there have been studies. Most of these studies have actually been out of Asia. Like Asia's an early adopter
Yeah.
of the M-block technique, and I believe it was a Japanese group where they looked at the margin, location, and the correlation with recurrence. And so
Mhm.
margins along the perimeter, so like superficial mucosal positive margins versus deep margins, had a differential in terms of recurrence risk. And they found actually no increased risk of recurrence among patients with tumor at the margin,
Mm.
but
Okay.
relative to those who had tumor that was deep. And patients who had tumor in the deep resection had high risk of recurrence, and those at the
Okay.
periphery didn't. And so, it's early data. It's hard to know what to make of that. I suspect that grossly, we do actually have a pretty good idea of what the perimeter of the tumor is with a papillary tumor, and
Yeah.
that will score around it. But you will get some thermal spread from when you cauterize. So
Sure.
you'll spot burn, but you'll get thermal spread. And so I think the pathologist is seeing cautery at the edge of where the tumor resection is, and they're assuming that you got pretty close, and there's probably tumor in the area that got burned.
Yeah.
And that's probably why we're not seeing a correlation with recurrence along those edges. But along the deep edge, the deep margin, if you're having tumor on the deep margin, you probably truly do have tumor on the other side as well.